Hi, I'd like to thank Dr. Shaker and Dr. Muscati for this invite. And though I believe scleral contacts are a tremendous advance in the field of keratoconus, may I encourage you to understand surgery as the first line of action for these patients to not only fix their vision, but permanently. So think outside the cone. May I show you patients and their reactions when you liberate them from this vision imprisonment and the lack of belief that these patients can actually see. Here are patients immediately after surgery, and I want you to get addicted to how they react.
Here she is, the girl from Wisconsin.
It is very important to understand these concepts as I keep showing you patient reactions in every presentation of mine. Here's a patient actually I saw yesterday, and you can see her after her major keratoconus surgical complications she had with other places before she came here. She actually went down this very treacherous 11-mile drive in the mountains called the Tail of the Dragon, and she actually
me down. Yeah, I'm trying. Yeah, I'm trying to balance me out. My feet can't touch the ground. Yeah, I'm flying. Yeah, I'm flying. Rapidly moving. Without you, I'm losing control. I need you.
And I get to do fun things like
So in all my presentations, you always see me showing my patients. I believe that's the highest level of accountability, and very important that we understand how they feel visually imprisoned just because doctors don't understand that they have the capacity to see. Here I am teaching actually a full course of surgical aspects that can be applied to keratoconus, right from corneal techniques to lens-based techniques to combination techniques like you see me doing intact rings here. You can see me doing lamellar corneal techniques here, associated hand lamellar or automated lamellar techniques for building the cornea in extreme cases. Mostly I use laser techniques on these patients. You can also see associated conditions in keratoconus that can be corrected. For example, patients with Fuchs dystrophy or pterygiums with keratoconus, they can all be very beautifully done. Don't think these patients are abnormal. That's pterygium cases, very advanced cataracts in these patients. Take them to 20/20. Do not believe that they cannot see. Actually believe that they can and take them there. It's possible. Here we are, ICL techniques, you name it. So keratoconus patients deserve all these techniques and concepts. Piggyback lenses, really no limits to how you can correct them. So I'm going to show you this, which is also important for me to make sure that you memorize this and don't forget these pictures. These are keratoconus patients. These are patients who are surgeons, attorneys, pilots. They are professional athletes. These are people in the real world, and they're back with their 20/20 vision. So not compromising their life and completely free with their visual freedom, that too permanently. So these are patients keratoconus in a single day that we fix, and they're all free to go back and be the best in their profession. I want you to see these reactions of these patients right under the laser.
I just finished doing LaZrPlastique on your keratoconus cornea with the very irregular astigmatism. Can you see anything at all?
I see. This is an immediate difference. This is, oh my God, I am tingling from the inside out. This is fantastic.
Any pain, Hector?
No pain whatsoever. None at all.
Super.
This is great.
Very proud of you. And I kept my promise. No pain, everything perfect.
No pain. No pain at all.
And for doctors who are watching, if you can see up on the screen, our reflex has become a perfect circle. I can look straight at the light. Beautiful. And that basically translates to vision, right, Hector?
Absolutely.
Congratulations. Here we go.
Always translates to vision. These patients enjoy and they make me dance with them. Whatever, I do it for them. It's okay. It's fun. Here's another patient who came with cross-linking complications, and again, see their reaction.
Manny, we just finished doing LaZrPlastique on your very advanced keratoconus. Can you tell any difference?
I can't believe it. I'm shocked. I can see much clearly. This is unreal. Much more clearly than ever before.
The girl from Wisconsin.
Again, remember, he was demanding, skeptical, well-researched patients. Both of you crying, guys. Dancing, having fun because they've been relieved of their
Thank you, Dr. Gulani.
Patients with scars of keratoconus can also be corrected, as you can see here. In fact, this is an acanthamoeba scar. And all of these scars, as you know, my in-cornea, on-cornea techniques with Corneoplastique.
Very nice.
Look at the face.
Super well. Excellent. I just finished doing laser on your corneal scar, acanthamoeba scar. Can you tell any difference?
It is a lot more clear. Things are sharper.
Wow.
The image is sharp.
Fantastic. Any pain at all?
No pain.
Well, we're so proud of you. How many years have you suffered with this blindness?
14 years.
Very happy for you. Very happy for you. And for doctors who are watching, this is a acanthamoeba scar. You can see the reflex of the perfect circle. That tells you, again,
Perfect circle. Here's another patient. This patient is very complex keratoconus patient.
finished doing LaZrPlastique on your keratoconus. Can you tell any difference?
Yes, the light is clearer.
Yes?
Yes.
Fantastic. Any pain at all?
No, none at all.
Super. For doctors,
Keratoconus patients from moderate, mild to extremely severe that I will show you, but their reactions are all the same, no matter where in the world they've traveled from. Look at this patient from South Africa with associated extreme astigmatism and nystagmus. And you can see that all the cellular I designed especially extremely open, so it doesn't move while I'm doing the LaZrPlastique technique. And you can see their reaction, their happiness, and she in fact flew to California for skydiving before going back to South Africa. Patients with extreme myopia and astigmatism with stable keratoconus can even have phakic implants done. So you can see these kind of cases. I use the Vision ICL, though we've experienced with all the 6 different phakic implants in the world. And again, bring these patients to 2020. Patients with cataracts with keratoconus. Here's a patient from Abu Dhabi, and again you can hear
great, Jack. Everything's going fantastic. You okay?
Oh,
the reaction of this patient while I'm in their eye, and they have no anesthesia. Most of my patients with cataracts
Inside your eye,
they
just
can
behave
use
like a
the
patient now,
eye
Jack.
drops, even in
Perfect.
such complex
Wonderful.
cases. And here he is, and that same night he hired this bike to and encouraged me to sit on the back, and my confidence on sitting on the back of his bike, where he had surgery that morning with his complex keratoconus cataract, and he took me for a ride before going back to Abu Dhabi. Very important to see these concepts. Then new technologies that we use can also be used for keratoconus. For example, using the intracameral steroid that we use, that patients don't have to use eye drops anymore, right? That's the technology. Right here you can see me, the little ball, the sphere of white that you're seeing going inside the eye, they don't need drops anymore. Then the other concept of using steroid-based lacrimal plugs in these patients called Tecnis. You can see that being inserted in these patients. And of course the tissue or the glue, the ReStor sealant that I'm using in these cases for no stitches. One of the most complex cases I have done, not because of the extremeness of the keratoconus, I've done up to 38 diopter astigmatism, though this is 24.7 astigmatism, but the cornea was just close to 100 microns thickness in the center and in the area where I'm doing the surgery. And you can see the ring I have placed in one area and compression sutures on the other, took them out to stabilize the cornea to perfect stability in this patient, avoiding a full transplant. Patients like these who came to me with, this is not keratoconus, but surgical keratoconus, hexagonal keratotomy, that's severe ectasia, about 90 diopter keratometry, 23.5 diopter astigmatism, and we brought them to 1.4 diopters and then did a cataract.
This is a
surgery for this
75-year-old
patient.
nurse who was
Paucity of
referred
time,
to
I'll
me
just
following
go fast.
hexagonal keratotomy.
You can see here that patient straight to 2020. And this is why I want us to look at every patient with keratoconus, no matter how severe, and actually give them this freedom that sets them free. So how do you define keratoconus? May I encourage you not to get scared by that word and decrease your desire and the patient expectation. In fact, break down keratoconus into a condition that is stable or unstable with relatively thin cornea, high keratometry, astigmatism with myopia or hyperopia. It's an exercise in futility to grade keratoconus, score it, label the patient as complex, and then do nothing. That doesn't help anybody. Similarly, crosslinking confusion. Don't cross-link keratoconus patients and leave them disabled. Crosslinking is a very important concept I'll share with you later. But stop this discussion of epi on, epi off, protocols, what do you use, how thin the cornea. Crosslinking cannot just crosslink a patient and leave them dependent and disabled. That's not the end goal, right? Raise the bar. Dependence on a contact lens or delaying a transplant should not be a goal. Delivering vision should be a goal. No harm in falling short of your goal and then needing scleral contacts to make them see. That is absolutely fine. So avoid distractions. Looking at topographies and doing courses and conferences means nothing. It doesn't matter how irregular the cornea is. Fix it. Same as I show you here. And then what is important to me is how I go after these patients and believe in their vision and actually refract them myself despite all the technology in the world. This is the key point in keratoconus.
Love it, Mom. Love it.
That the patient can see. Then my 3T system, which defines technology, techniques, and target. Very important again. Do not be limited by this is all I do, a Lasik, a smile, a ICL, a cataract. No, I want all 40 techniques to be the realm of every eye surgeon. Take, for example, this case. Now I'll start showing you how I think. A patient who was sent to me having had premium cataract surgery through his keratoconus was ended with hyperopia, open capsule, presbyopia, central scarring, high keratometry. A horrible situation for a pilot. Patient was in a lawsuit. His surgeon had him travel over to me. Again, see what I did. I never like to think barbaric surgery. Always think logical. How do I make him 20/20? My first thing is to believe that the patient can see 20/20. Then I start walking backwards to understand the least interventional way to artistically give them vision. So let's pick all the pins in this case. Patient has a corneal scar, high keratometry, high astigmatism, hyperopia, and pseudophakia but open capsule. So you don't want to exchange the lens. Yes, surgically I can show all my skills, remove the lens, do the vitreous, but that doesn't get us to 20/20. So what did I do? So here my concept was if I need one surgery to fix this patient's scar, high keratometry, central emmetropia, or everything, it would be myopic laser surgery. But the patient's hyperopic. So I start defining how to create myopia. So what I call this is going to Paris but through Iceland. The patient and you have to be confident to hang on to the journey. So I first put in a piggyback lens and made this patient actually myopic, which was my goal. And patient's vision obviously was bad, but his confidence in me and my confidence in where I'm headed. So, and then I went in and did piggyback. After getting myopia, I did a LaZrPlastique surgery. Now I got all my errors. Myopia, astigmatism, scar, keratometry, larger zone. In fact, this patient landed at 2015 vision without glasses and went back and got his pilot's license. So here's my thought process for keratoconus. If a patient's vision is better than 20/40, astigmatism with myopia, more than 400, stable, regular, no pathology, I'm doing LaZrPlastique, as you saw me do, right? Here is how I do these cases. For example, this firefighter, you can see he's at 0 with LaZrPlastique, vision of 2015, astigmatism straight to 0, even topographically. And these people are back into their lives. Then patients who come to me who've had multiple surgeries also, like this gentleman in Canada, California, all over the world, had multiple cross-linkings, but they had left his vision uncorrected. That's the point I'm trying to get to. Cannot just stabilize the cornea and send the patient home blind, right? So this patient we brought straight to 20/20. How I tackle in-cornea scars and on-cornea scars, as I've taught y'all before, and that takes straight to 20/20 in these cases. Now, take patient cases who are 20/40, myopia more than astigmatism, more than 400, everything stable and regular. Now I'm going in the eye and doing an ICL or a phakic lens to make this myopia, which is a higher criteria, in a stable cone, straight to vision. As you can see here, we're experienced with all kinds of phakic implants in the world. My present preference, the vision ICL. Even in cases like this that came to me, this is a baseball player who came with severe granuloma, with stem cell deficiency, with high myopia, with keratoconus, thin cornea. And I put in an ICL after a collaboration with my colleague. We did an amniotic surgery first, corrected the granuloma, and then went straight to vision. Take, for example, patient more than 20/40, but high astigmatism, hyperopia, stable, regular, and a cataract. You're going straight to cataract surgery, what I call LaZrPlastique surgery. Even though the cornea pre and post-op has the same astigmatism and irregularity, the patient is at 20/20 because we basically corrected optically the anatomical problem. Various lens technologies can be used in keratoconus, absolutely can be used. Even the new X-Wave technology is great. My present choice for keratoconus patients with cataracts, patients with extreme situation like this, excuse me, high irregular astigmatism with keratoconus, and nystagmus, as you can see. Nystagmus, as you can see, in a patient with albinism. Patient had albinism, amblyopia, very high irregular astigmatism. You can see here, but even these cases can be corrected and you can put them back in their lives. Then you can see in these patients when the vision is more than 20/40 but high astigmatism, cornea more than 300, less than 400, stable, regular, and no pathology. Here's where I'm doing cross-linking on these patients and stabilizing them to a better vision or to a vision out. My concept of cross-linking is called keratoscoliosis concept that I've defined over a decade ago, is not to cross-link. In these words, I'm showing a spine and it's bent. Don't put cement on the spine saying it won't bend anymore. That's correct. But then you haven't corrected the spine. So that's a disfavor to the keratoconus patient that you're keeping them disabled for life. So cross-linking, which is a very important part of treating keratoconus, must be done. But after you have fixed the keratoconus cornea, made the patient see to their best capacity, and then you can permanize that shape with cross-linking. Of course, there are other indications which are early, young age patients where the keratoconus keeps changing, but most importantly, do not use the cement on the bent back until you fix the bent back and made it straight. All right, there you go. Complications of cross-linking, as I mentioned to you, we correct all the time, and they can easily be corrected like I showed you all in the video. Here's my thought process and how I go through at this level of the treatments for the visions less than 20/60, high astigmatism, less than 400 cornea, unstable, irregular with ectasia. This is where I go into Intact surgery, which are directional rings that I put into the cornea, which not only stabilize the cornea and give it strength, but it's directional. So it also, as you can see, this is my technique. And what I do here is create channels with laser or manually, depending on the complexity of the case, and put in single rings, double rings, plan it along the axis. And this is again no stitch tissue or glue sealant that I'm using on the cornea. You can see these patient reactions that is so immediate. I don't want you to forget this. That's why I keep showing you patients how they react, how they cry, even with Intacs, which is now called the Gulani T Intact technique or the titratable technique. They start seeing the perfect circle right under the laser.
So Anthony, we just put a special ring to control your complications for the LASIK surgery. Look into the light. Can you tell any difference?
I can tell her hair right there. I can see her head ring perfect.
Wow.
And I can see the square around that. I can see that square ring around that perfect, no glare.
Wonderful. Wonderful. Excellent. Congratulations. Keep your eyes closed. You fixed it. Very positive. Anthony, come on. Give me a smile. Tough guy like you crying. I don't want it. Get up.
Going on to seeing how these Intacs can correct all kinds of ectasia, even here from, as you can see, from 10 diopters going down to 0.1. Patients with LASIK ectasia, which is like a surgical keratoconus, 7 to 0.6, 23.5 to 1.4. So there is no limit to what you can correct, as you can see here, right? All kinds of ectasias can be corrected, even ALK ectasias. And it doesn't stop there. After you've controlled the cornea and built it with the ring, you can still do LaZrPlastique on top to correct the residual astigmatism or refractive error. Patients who came in to me, like this guy with the Ferrara ring from abroad in Europe with broken ring, they asked me to remove it. I said no need for removing. The surgeon did a good job. The ring's doing its job of stability. We did LaZrPlastique on top, straight to vision. This patient from Egypt had multiple surgeries, not only in Egypt but London, Germany, all over the US, and corrected straight away to vision. Doesn't matter how many surgeries they've had. And you can see the impact there. Vision less than 2100, very irregular, very unstable, less than 200 cornea. Here is where I need corneal tissue to build the cornea. That's when I do lamellar keratoplasty. Remember, never penetrate. So you can see here in this technique video, again for paucity of time, I'll go fast. You can do automated technique and lamellar techniques, and you're constantly making sure the cornea is stabilized and freshened up for future refractive surgery. That's the goal. It's not just the surgery. You're now building it up for future refractive surgery. That's hand lamellar technique. Again, all these videos are on my YouTube for you all to see, but this is just to give you a glimpse of where we are headed. And
this is a
all
case
these
of a
patients
very
can be
advanced
rehabilitated back to normal vision. And you can see what lamellar keratoplasty does. It doesn't correct the astigmatism, but decreases the keratometry, clears the cornea, adds tissue for future correction. This patient from Switzerland came in with extremely high myopia with astigmatism, posterior polar cataract, keratoconus, with an intact ring, and then I went inside the eye and put a toric premium lens straight to 20/20. So you can see combinations are very, very, very impactful in these cases. This physician had 12 procedures before coming to me, completely blinded, 2200 vision, and had all these techniques before coming here. But it doesn't matter. He had PDK, PRK, cross-linking multiple times, ICL, and now he had a cataract with the intact rings and keratoconus. So we basically did a LaZrPlastique, made him measurable. Then I removed his cataract and his ICL, and then kept the bag open, as you can see here. And then a week later, on refracting the patient, went inside and placed a perfect, stable toric lens implant to 20/20 vision. That's the ICL coming out. That's the cataract part. And then I come back a week later and I put in a toric premium lens straight to 20/20. And of course, I keep showing you patient reactions because it's very important for you to be understanding that surgery can help these patients, even with previous multiple surgical failures, to bring them to 20/20. With that, I'd like to thank you all for your attention, and may I encourage you, please, to think outside the cone. Dr. Gulani.